Thank you. I'd like to start by acknowledging Farah Hodroj and Nick Scott, who led the work. Farah did the bulk of the work here and guided by Nick, who's the head of our modelling team. Can you do the...
Yeah, of course.
I'd also like to acknowledge the traditional owners of the land on which I work, the Bunurong people of the Kulin Nation, and pay my respects to their elders past and present. And I'd also like to acknowledge and draw attention to the burden that Indigenous people around the world experience in relation to incarceration and also their experiences of bloodborne virus transmission as well.
So we'll start off this presentation sort of reiterating what I said in my talk, but that prisons are high-risk settings for bloodborne virus acquisition. And that's primarily due to the disproportionate incarceration of people who inject drugs, and therefore the higher prevalence of both HIV and hepatitis C in prisons versus surrounding communities. There are also prevalent high-risk behaviors, and in the absence of harm reduction services, lead to the transmission of these bloodborne viruses. As you've just heard, prison needle and syringe programs reduce the harms associated with injection drug use among people both in prison and in the community. And these are evidence-based interventions that are endorsed by the WHO and other UN organizations. For the purpose of this talk, we will describe PNSPs as PNEPs because the Canadians call them prison needle exchange programs. So PNEPs, as you've just heard, exist in 9 of 173 countries as of 2023, and they were introduced in Canadian federal prisons where people are incarcerated for where people are sentenced for greater than 2 years in 2018. So this is a map of Canada. We have 43 federal prisons, and in 2018, PNEPs were rolled out in 9 of the 43 prisons. Female prisons were prioritized to male prisons due to the higher prevalence of injection drug use. And unfortunately, the reach in 2022 was only 10%, i.e. 10% of people who were injecting drugs in prison were accessing the PNEP. The Canadian PNEP service delivery model is anything but low threshold. It's a complex, convoluted model. And the costs related to this model are related both to human resources as well as commodities. I'm going to take you through the process, and you can also agree how convoluted it is. So on admission, there's a newcomer intake assessment. So a nurse spends some time with a new admittee to review their history of injection drug use. The PNEP is introduced at that time. And enrollment does not occur simultaneously or automatically. The individual must put in a participation request form, at which point a second meeting is made with a nurse who assesses this individual's cognitive and physical capacity. If deemed appropriate, the nurse sends a threat and risk assessment to the chief leaders of the prison. So at that point, the application must be reviewed by a security intelligence officer who reviews every stay in every prison to ensure that this individual has no history of using needles as a weapon. And then sign-off must go through the assistant warden of operations and the warden, and then trickles back to the nurse, at which point they're approved. So not an automatic approval process, and this process typically takes 2 weeks. 1 kit is administered at a time, and for the purpose of this modeling, we used Swiss data to suggest that on average, people exchange on a 1-to-1 basis twice weekly. Just also to note, in the Canadian model, there are twice daily security checks that happen during counts, whereby an individual must demonstrate that he or she has their kit to the correctional officer and that all the kit contents remain in the kit. And so with that, our aim was to assess the impact of Canada's existing PNEP on hepatitis C cases and injection-related infections, IRIs, and to project the benefit-cost ratio of a gradual PNEP scale-up to all 43 federal prisons, reaching 50% coverage of people who inject drugs in prison. We modeled 3 scenarios: 1, counterfactual without PNEPs; 2, the status quo, where the current PNEP implementation in the 9 federal prisons would remain at 10% all the way through; and then scenario 3, where we scaled up PNEPs to the remaining 34 prisons between 2025 and 2027, and then coverage increasing linearly from 10% in 2025 to 50% in 2030.
So we developed a simple stochastic compartmental model. Outputs were estimates of HCV and injecting related injuries and infection incidents within the entire Canadian federal prison population. In terms of input data, these were provided from publicly available sources, primarily from Statistics Canada and Correctional Services Canada, and included over 12,000 individuals housed in federal prisons. Just over 20% of those reporting a history of injecting drug use, and the assumption that approximately 40% of those with injecting histories continue to engage in injecting drug use while in prison. Those later estimates were taken from largely concordant results from 2 studies in Australia, given the absence of that specific data in Canada. The baseline hepatitis C incidence in the model was 25.4 per 100 people who inject drugs per year, and the HCV RNA prevalence was calibrated against Correctional Services Canada data that showed a decrease in prevalence from 21% to 3.2% between 2010 and 2021. In terms of the methodology, individuals entered the model, the blue lines, based on a fixed rate of incarceration and classified as either susceptible or potentially contributing to incident infections based on their injecting and HCV RNA status. Individuals have a probability of becoming infected with hepatitis C or getting treated for hepatitis C or experiencing an IRI, which is the solid black arrows in the model. The dashed arrows denote individuals that exit the model by being released from prison, calibrated on the basis of general sentence lengths from publicly available data. We did not model mortality as an exit in this model because rates of mortality in prison are relatively low and would be evenly distributed across scenarios regardless. The red box and arrows denote the impact of prison NEPs on reducing the probabilities of experiencing IRIs or a hepatitis C infection. In terms of costs, as Nadine noted, this is actually quite a costly program, and I suspect that if we did this in other parts of the world, we might get even more beneficial results. But the costs were calculated from a health and correctional systems perspective and included startup costs, one-off prison NEP initiation costs per participant, costs associated with the exchanges of kits, and general operational costs. Benefits were based on the healthcare costs averted from prevented hepatitis C and injecting-related infection and injury cases. HCV treatment costs were the drug costs plus the costs of community models of care sourced from publicly available data in Quebec and in Ontario and discounted to 2/3 on the basis of in-prison treatment models. IRI management costs were taken from a 2021 paper, Canadian paper, and converted to 2023 Canadian dollars, and the simple benefit to cost ratio was calculated as the benefits divided by the total costs. In terms of the headline figure, in terms of the impact of prison NEPs on reducing incident cases, in prison it's highly dependent on some program scale-up. Between 2018 and 2030, the status quo scenario averted an estimated 20 new hepatitis C cases and averted 3 IRIs, and a relatively modest reduction in hepatitis C incidence from 3.8 to 3.7 per 100 people who inject drugs per year. But in the scale-up scenario, compared to the status quo, an additional 112 HCV cases were averted and 55 injecting-related injuries and infections averted. And HCV incidence in prisons declined considerably, down to 1.3 per 100 people who inject drugs per year. And they're cost beneficial in either scenario, really. The current status quo saves about $2 in healthcare costs for every dollar spent, and in the status quo scenario, and over $2 in healthcare costs averted for every dollar spent in the scale-up scenario as well. And would like to note that 84% of those cost savings come from averted hepatitis C cases.
So our key takeaways from this study is that this is the first study to model the cost benefit of Canada's operating PNEP in federal prisons, and its scale up may be more important as we potentially go into a Conservative government in the next year or two. There was a positive impact with more than a twofold return on investment through predominantly reduced hepatitis C treatment costs, and that was how I answered Simon's question. Scale up to 50% coverage of people who inject drugs in prison by 2030 could prevent 14% of new hepatitis C cases, 6% of injection-related infections, significantly reducing hep C incidence in federal prisons and potentially eliminating hepatitis C. We will note the Canadian PNEP model is unique. It's administratively intensive, but it does provide a framework for global adaptation and optimization. And future research should focus on comparing different PNEP delivery models to optimize cost effectiveness and access. And this study underscores the importance of tailoring PNEP to specific carceral settings and streamlining implementation to maximize program participation, health outcomes, and economic returns. So with that, we'd like to thank you for your attention.
We have 3 minutes for discussion. I think there's a question on the front. Jason, please. The mic is coming.
Thanks for the continuous water.
Jason Grebley. Amazing work, you guys. This is so important. You kind of alluded to it in this sort of third, anyways. In the slide. Have you guys modeled any scenarios? Because obviously the administrative costs, I couldn't say, maybe it was about a quarter. I don't know how much of that was startup and other stuff. But have you sort of done something where you say, if this pathway, the startup and continuous pathway, if it was simplified and those costs were removed, and what that, because I'm assuming it would help even further, and could you even use that as like an investment case to be like, look, this model is pretty burdensome. If you did this, it would be even more cost effective. And do you think that would even work, tying it to our discussion earlier?
Yeah, maybe I'll just take it. So to answer your question, no, we did not do that for the Canadian model, but Mark will speak to an Australian version of this study that we did. Listen, Correctional Services Canada has what seems to be limitless money. And so I do not actually think they care if this is cheap or expensive, okay? Which may not be the case globally, but Correctional Services Canada is literally spewing money. So this argument may help a Conservative government, but is of no relevance to a Liberal government. That said, their 2024 to 2030 framework for the elimination of STBBIs in Canada, one of their top goals is the scale up of the program. And so maybe when we scale up and the costs become more of an issue, even though we didn't really show that they were, maybe at that point it'll become more important. But I would say right now money is not the concern.
So what we've done, Jason, is also apply this model to a fictional prison NSP program in Australia, calibrated to Australian data. As you know, myself and others in the room have been smacking their head against the brick wall in Australia, and it's a I think it's an absolute disgrace that a country that once was at the forefront of harm reduction globally has never implemented a prison NSP program. I just find it amazing. The model that we put in there was actually one I developed and put forward as the model for the Alexander McConaughey Centre in Canberra, which is a much simpler model than this. And yeah, that's been accepted and will probably be published in the Medical Journal of Australia next year, early next year.
BCR is your study? Do you remember what the BCR is?
Thank you.
Yep. A quick question and a quick answer.
Yep. Carla Trelaw from UNSW in Sydney. We've shown cost to individuals of the unregulated prison needle and syringe program. Have those costs been able to be accounted for in any of these models? Costs of drugs, costs of needle and syringes, costs to people on the outside to provide these things, costs in terms of fights and other things that happen in prison?
No is the answer. Yeah, I think they're very legitimate things to factor into these types of models. As you make models more and more complex, they become more and more complex. We wanted to, you know, this is the first work that's been done on an operational program in the world. You know, I think we can start simply by saying these things are cost effective, and I think it would be really interesting to build on some of that data, Carla, and maybe we could talk afterwards about how we would develop a more sophisticated model that would then talk to, you know, some of the human rights and other issues associated with the current status quo. So that would be really interesting.
Thank you. Now, we are running out of time, sorry.
Mark?